let's talk about monitoring patients with HIV, laboratory monitoring. How often do you do CD4? How often do you do HIV RNA monitoring? Do you do it do you do it periodically? Is there a schedule? Where do you go?
Yeah, so it's funny because it's something that I think we've all laughed at ourselves in clinic for years and years, because we would routinely order these tests every time people came in, and we often saw them often, and then we would never do anything with the results. So I think people
Especially the CD4.
Especially the CD4. So people have sort of revisited this, and I think there's a consensus. You want to know what the CD4 is at baseline to know whether they need to be on any prophylaxis. And usually you get a baseline viral load, or even that arguably, unless it's undetectable, is usually useless, because your goal of therapy is undetectable. And I don't care whether you started at 1,000 or 500,000, the goal is the same. And then we monitor viral loads pretty close at the beginning. And some of this is probably with the idea that if they aren't responding well or they're experiencing failure, we want to know it earlier than later. My guess is it's more a marker for adherence.
Okay.
For us, that we're using the viral load. We're not going to do anything based on the CD4 for months and months. So the utility of doing a lot of CD4s early on are useless. So we do the viral load, and once the person's undetectable, then the only reason we're doing the viral load is to see if they experience viral rebound. And there's a general consensus, and there's data that suggests that once somebody's undetectable for a long time, they're not likely to rebound unless something happens.
So when do you check?
So we're doing it less and less. So usually every 4 to 6 weeks, viral loads at the beginning, until their viral load's undetectable. With integrase inhibitors is often in the first 8 to 12 weeks. And then probably most people will do it every 3 months or so for the first year. And once things stabilize after a year, every 6 months is probably more than adequate. And we probably have some people who've been undetectable for 10 years, where once a year may be fine.
Yeah, I'm certainly starting to go to one, now that I don't worry as much about nephrotoxicity of TDF, I've gone to once a year in a lot of my patients. The interesting thing is we've trained so many of our patients to want to know their CD4. It's actually a little harder to completely get rid of the CD4, but I think most of us would agree that once your CD4 is above 350 or 400, you could probably just get rid of it, right? I mean, just never do it.
It's not necessary. It was a habit. It was hard to break.
And you never, ever react to it. All you do is talk patients off the cliff.
Off the cliff.
Yeah.
Because there's a lot of variability at the higher numbers,
Right,
just based on the
let me give you
math.
some other tests.
Right.
I have a feeling I know where we're going with these. Hep ABC, serum chemistries, blood counts, creatinine clearance, urine glucose, proteins, lipids, dogs and cats, sleeping together, SMA 20s. What do you do with all that?
Well, I'll take A, B, and C. So I think for viral hepatitis, everybody gets checked at baseline to see if they're immune to Hep A and Hep B. If they're not immune and they don't have chronic Hep B infection, they get vaccinated. So it's important to have that at baseline. And then if they have chronic Hep B, then we treat them as we talked about earlier. For Hep C, everybody gets tested at baseline, and if they're negative, I think one of the things, probably the most common thing in the guidelines that's missed in a lot of clinics, including ours, although I hope less, is that high-risk individuals, which now extends beyond people who use needles, but also men who have sex with men, should be checked probably annually, because we recognize an increased risk of transmission within these populations.
The test that we're doing most frequently now is screening for sexually transmitted infections.
Okay.
So RPR, GC chlamydia, not just urine, but rectum, pharynx, and there's some people that would argue that those should be done every 3 months. You know,
For certain people.
they recommend that be monitored more closely than the viral load.
Quickly, serum chemistries, glucose, creatinine clearance.
So you know, we do monitor those. So those are the safety monitoring labs. They're now not quite as critical, as Joe mentioned, because the tenofovir formulation is less nephrotoxic. Definitely want to check lipids because, with the aging population, we want to treat those if they're elevated.
Yeah.
So.
And the populations that we care for, at least in North Carolina, super high risk of diabetes, right? They're 60% black in our population. That one thing happens when people get on therapy is they gain weight.
Oh, tremendous.
Obesity is a problem. Obesity is a problem in our clinics.
So in addition, some of the more toxic antivirals we used in the bad old days caused lipoatrophy. And lipoatrophy is strongly associated with diabetes and glucose intolerance.
Okay, I just want to point out that if you're worried about obesity, you're winning this.
Right. Well,
totally.
yeah, but
Although we're losing it on the other end.
Losing on the other side. What about genotypic resistance on reverse transcriptase, things like that?
So the current recommendations are that we're supposed to do it at baseline to look for transmitted resistance, and I think that's reasonable. The current recommendations are, since most people have to order a separate test for integrase resistance, is to not do that as a matter of routine,
Okay.
unless you're worried the person may have been exposed to somebody. And then we do it when people experience virologic failure.
You know, as you know, we presented at CROI a modeling analysis on this question of whether to do baseline integrase testing. And essentially, the answer is no, because the only reason to do it is to then ignore the result. If you're using a dolutegravir-based regimen, you're still going to virologically suppress most patients if they have integrase at baseline. And if you don't suppress them, you're going to switch them within 8 to 12 weeks to something else, which is, of course, what you do anyway.
And also you're
there's really,
testing for something that's been reported
there's
5
really,
times.
there's really almost no indication.
So
to do
even when we start seeing transmitted resistance, that may be
So-
the case.
so-
Right now, we don't even see it.
It occurs at a rate of 1% at most in some series, and a lot of them are polymorphisms that don't affect
Yeah, in
outcome.
fact, I mean, I keep saying Paul is about to write this paper. Maybe he is, but that actually baseline resistance testing should probably just go away altogether.
We're working on that one. We're focusing first on the integrase question.
Right, but
You're right.
I mean, that may have unintended consequences because there's a lot of work being done looking at transmission clusters and things like that that help identify HIV spread that use that kind of free test.
That's right. That's not. But if
it's
you want to
not
know
that the
what's
test is free,
a
but the data are
rational
free.
use of baseline resistance testing would be not to get it.